morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to yet another edition of very educative lectures for you. The speaker for the first session of today is our distinguished and honored faculty from Argentina, Professor Graciela Zuccaro. She was the Chief of Neurosurgery at the National Pediatric Hospital as well as the Professor of Pediatric Neurosurgery at the Faculty of Medicine of University of Buenos Aires. She was the founding member of the Pediatric Neurosurgery chapter of the Latin American Neurosurgical Federation, and she was also the first female president of the International Society of Pediatric Neurosurgery. She has participated in various numerous local, national, and international neurosurgical meetings, presenting over 210 and 104 articles in national and international conferences, respectively. She has been part of the editorial board of multiple scientific publications, including La Revista Argentina de Neurocirugía, Child's Nervous System, Journal Brasileiro de Neurocirurgia, Surgical Neurology, and Journal of Hydrocephalus. We are extremely honored to have her today at our webinars, and today she'll be talking about surgery of pediatric craniopharyngiomas, conventional and endoscopic. The speaker for the second session of today's webinar is our honored guest from Colombia, Professor Andres Rubiano. Professor Rubiano is the Professor of Neurosciences and Neurosurgery, El Bosque University, Bogota, Colombia, and the Chair, Neurosurgical Services, Wellness Salute Clinical Network, Cali, Colombia. He is the President of the Colombian Association of Neurosurgery and President of Neurotraumatology and Intensive Care Chapter of the Latin American Federation of Neurosurgical Societies. He is also the Chair of the International Committee, Neurotrauma and Critical Care Section of the ACNS and the Co-Chair Neurotraumatology Committee of the WFNS. He is the International Director, Brain Trauma Foundation, USA, and the Vice President of Global Neuro Foundation, Switzerland. We are extremely honored to have him today at webinars, and today we'll be talking about strengthening neurotrauma care in resource-limited settings. The chair for the first session of today's webinar is an honored guest from Israel, Professor Shlomi Constantini. Professor Shlomi Constantini has been the director of the Department of Neurosurgery at the Dana Children's Hospital since 1996, and is also the director of the Israeli International Neurofibromatosis Center. He has received his training from Fred Epstein at New York University, specializing in complex brain and spinal cord surgical challenges in children, focusing on those that are most difficult to operate. Professor Constantini is active internationally while serving roles in global organizations such as immediate past president of the IFNE, past general secretary of the ISPN, president of the ISPN, and past vice president of the ANS. He has published over 300 papers in various period journals and over 50 book chapters, and is also a member of the editorial board of many journals. We are extremely thankful to him for accepting our invitation to chair the session of Professor Zuccaro today. The chair for the second session of today's webinar is our honored guest from Milan, Italy, Professor Franco Servadei. Professor Servadei is a senior consultant neurosurgeon at the Humanitas University and Research Hospital, Milan, Italy. He was the past president of the WFNS. Professor Servadei has published several articles and book chapters in various international publications. Trauma in resource-limited setting was one of his several research interests, and is rightly the best chair for the second session today. We are extremely thankful to him for accepting our invitation to chair the session of Professor Andres Rubiano. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs and the audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China. We are extremely thankful to our Vice President, Professor Shubin, for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this online podium to our first chair, Professor Shlomi Constantini.
Thank you very much. I'm sharing my screen now. Thank you, Raja. You're certainly the most fastly speaking person on earth that I know. Congratulations for running through this introduction. And I really welcome Professor Graciela Zuccaro to give this talk about craniopharyngioma. I told Graciela and Raja that I want to take, instead of 5 minutes, I want to take 10 minutes of setting the stage for Professor Zuccaro's talk, because I think that repetition on this subject, this complicated subject of pediatric craniopharyngioma, is not a disadvantage. It is actually an advantage. So I just want to remind you there is some history behind it. My esteemed mentor, Fred Epstein, I don't know, Graciela, if you were there, but in 1993, this is 29 years ago, made a focused meeting on craniopharyngioma, coined Craniopharyngoma, the answer. Of course, we came out of these 3 days on craniopharyngioma with more questions than answers. This is an idea that I took from Frederick Boop, the president of the ISBN, who made a slide, tumors I like and tumors I hate. And I dwelled about this and look at this scale. Above is like, and below is hate. So above are all the low-grade tumors, but look at craniopharyngioma. It is below the medullos, the PNET, and the ependymomas, and just above the extremely malignant tumors. And there is a reason why I hate craniopharyngiomas. The reason is that you have so many options, and there is so much potential morbidity associated with this treatment. And the options, just to explain the parents the options and what we can do and what we should do is extremely complicated. So this is from Frederick Boop, tumors I like and tumors I hate. And as you see, craniopharyngioma is quite low on this scale. So we have choices with craniopharyngiomas, and this is something that characterizes pediatric neurosurgery. So many choices to do in a single patient. And what we do, we're shifting decisions to the patient. So this is a new model which is being spoken about very often now, which is called shared decision-making model. But this takes a lot of time, and not all families are really able to be a partner in this decision-making between the different options. So it started with Harry Cushing, so one of the most baffling problems to the neurosurgeon. So about the epidemiology and clinical features, I'm sure Professor Zucchero will discuss, just to mention that not only an MRI is important, but also a CT scan. Those little flecks on the CT scan can give you an idea of where the capsule will be more attached or less attached. This was the first attempt from Puget to classify craniopharyngiomas. Why do I mention it? Because even from the Paris group, who was a very aggressive group to deal with tumors with Christian St. Rose, they started to realize that some of the craniopharyngiomas should not be involved. And I'm sure Graciela will talk about the ones that are just below in the sella turcica, the ones that push the hypothalamus upwards, and the one that involve the hypothalamus, which is a really disaster to operate. So what were the measures of success? Before 1970, it was morbidity and mortality. If the patient was alive, if he moved his hands and could see, it was a success. Later on, it became Glasgow Outcome Scale. In the adult world, they use the Karnofsky scale, but in the new millennium, we want a detailed neurocognitive measure, neuroendocrine evaluation, formal neuro-ophthalmological evaluation. Of course, what happens on the long term with the MRI and not only the CT scan. So it all started with the cowboys. So Gazi Yassergil, of course, our teacher, was one of the first cowboys with this paper on 144 craniopharyngiomas. But even Yassergil said, experience has shown that the larger the tumor, the greater will be the damage from the surgery. And then it continued with Harold Hoffman from Toronto, aggressive circle management of craniopharyngioma. Now I think that Harold Hoffman, being a master surgeon, also inflicted a lot of damage, because he would do, and I've watched that, those blind movements within the third ventricle through the lamina terminalis. And I think the evaluation of the patients was not true. This is something that people in Toronto acknowledge today. And then more papers came. This is from Jeffrey Wissoff, that for the first time admitted that even after GTR, this is on 49 patients, even after GTR, 24% recurrence rate. The recurrence rate after GTR probably is close to 50% if you wait long enough. And this is another paper from a very active group in CHOP that said, for the first time, that you have to combine surgery with radiotherapy, and that surgery, even if it's partial surgery with radiation, is quite equal to gross total resection in terms of recurrence. And then that group, the group from St. Jude with Thomas Merchant, also looked at the morbidity of 48 patients, admitting that the morbidity with aggressive surgery is extremely, extremely high. And now look at those pictures. Is this a good result? You see the morbid obesity, the hypothalamic obesity that I'm sure that Graciela will deal about. So the BMI increases significantly. The child who was an excellent student after treatment struggles to make C's at school. There's personality changes and emotional outbursts and memory problems. So then the paper started to come out looking at the quality of life and not only of the measures that were classical in the 70s and the 80s. And then those papers came out. This is look at the upper graph on the right side. Look at the GTR. The GTR in 10 years is about the tumor control rate is about 50%. This came from extremely, extremely good and aggressive groups. And then this paper that came out for Muller really has a tremendous amount of information from the German registry, Craniopharyngiomas. Always when you see a K instead of a C, you know that it comes from Germany, and that it says radical strategies leading to posterior hypothalamic lesions are not recommended. And more papers that came out, and then the classical papers about radiotherapy for pediatric craniopharyngoma. And then there was a period where we believed that intracystic therapy is wonderful. It started with phosphorus, bleomycin was supposedly make the capsule better for surgery, and then the interferon alpha. And I was part of this group. You see the paper on the lower group, and basically the summary of this paper, which is the largest cohort of intracystic interferon, is that the therapy is a temporary measure, if at all. And then the protons versus photons dilemma, and this is the first paper also from St. Jude, showing that the academic achievement scores in protons is better than photons. Whether to believe it or not, I'm not sure, but at least this is some kind of evidence. This is an opportunity to invite you to Jerusalem in September. Over 350 invited speakers with a very, very heavily biased plan towards pediatric neurosurgery, and come to the ISPN in Singapore in December. Thank you very much. This is good timing to give Professor Zucchero the stage to give her talk about craniopharyngiomas. Thank you.
Thank you very much. Sorry. It is an honor for me to participate in this webinar. When today my topic is surgical treatment of pediatric craniopharyngoma. I will talk about surgical treatment. Craniopharyngoma, as Shlomo said, is an infrequent tumor. That is why an individual surgeon's experience is limited, and therefore there is a lack of consensus regarding the best managed option. Over the years, there have been different options. The treatment option is gross total resection, subtotal resection with radiotherapy, cystal separation with radiotherapy, only radiotherapy, lately intracystic injection of yttrium that is no longer used due to its toxicity, same with bleomycin. Lately, interferon is being used, but only in purely cyst craniopharyngoma. However, its results are still questionable. As Theodore Birro said, only the man who is familiar with the art and science of the past is competent to aid in its progress in the future. The first probable mention of craniopharyngoma was in 1590. At that time, wealthy families would ask for an autopsy after the death of a family member to know the cause of death, because there was not other diagnosis method. In this case, an autopsy on an 18-year-old with a history of amaurosis and polyuria found a cyst in the sellar region. This could have been a craniopharyngoma. In 1579, Bonnet, a pathologist from Geneva, described various autopsies of children that had died blind with tumor in the cellular regions. 100 years later, the first series on cellular tumor was published that included cyst tumor of the cellular region. But it was not until 1904 that Herden, an Austrian pathologist, described the histology, and 5 years later, Haster operated the first case via transsphenoidal surgery. In 1912, Harvey Cushing operated 18 patients with craniopharyngoma, of which 14 died, and he penned the term craniopharyngoma. Between 1930 and 1940, he operated 87 cases with a 40% mortality rate. And he penned the famous phrase, "These cases offer the baffling problem which confront the neurosurgeons." Between 1918 and 1940, mortality rates were still very high, and other treatment options were starting, like radiotherapy in high doses. But as of World War II, with neurosurgical advances that had been achieved, such as angiography, encephalography, ventriculography, steroids, in addition, the severe complication that radiotherapy caused in children's brain, gross total resection was once again considered to avoid radiotherapy. As Shlomi showed, in 1946, Ingraham and Scott operated 15 cases with a 25% mortality, and Grant 30 cases with a 20% mortality rate. Until in 1969, when Manson publishes 57 cases with a 0 mortality rate and with total resection on 34 cases. Hoffman, in 1975, impulsed total resection to avoid radiotherapy in children, and penned the famous phrase, "Perhaps the most important factor is the neurosurgeon attitude toward the tumor. If he or she regards the tumor as not resecable, it will be treated as such, and no attempt will be made to remove it. If, on the other hand, the surgeon feels that the craniopharyngoma can be totally removed, its management is likely to be successful." The controversy that continues to exist today is total resection versus limited resection plus radiotherapy. We must take into consideration that in children, the histological variant of craniopharyngoma is the adamantinomatous type with mutation in the beta-catenin. However, in adults, the papillary type is predominant, whose mutation is in the BRAF clonal. It is probable that in the future, when an inhibitor is found for this mutation, surgery can be avoided. Meanwhile, we strongly believe that the first approach in a child with craniopharyngoma is to attempt total removal, because to remove a craniopharyngoma which has been treated previously with other methods such as radiotherapy, intracavitary radiation is much more dangerous due to adherences to vascular and neural structure, except in 2 cases. In prenatal craniopharyngoma, that is subfial, we prefer subtotal resection and reoperation when necessary. The other situation is when the craniopharyngoma involves the hypothalamus. In these cases, subtotal resection plus radiotherapy is a good option, as was shown. There are some MRI images that intend to inform if the hypothalamus is or not comprised. But in our experience, this is not certain, and only during the surgery itself can the surgeon experience truly evaluate if the hypothalamus is involved or not. That's why, for us, that imaging doesn't work. The tumor anatomical situation determines the surgical approach. In cases of intracellular location, in this case, which is the less frequent in children, and in cases of prechiasmatic location, that's here, we perform endoscopic endonasal approach. This is the position in the operating room. This is the position of the fixed head, elevated 10 degrees and rotated 30 degrees toward the surgeon. The CT scan is very important to show the type, to see the type of the sphenoid sinus. As we see when it is conchal type, we have to drill the same in achieve reaching the cellular floor. We approach by nostril by using a 6 millimeter diameter endoscopic positioned in the left nostril. We perform suction and resection via the right nostril. After the middle turbinated push, nasoseptal flap is prepared in all cases and put it in the nasopharynx to avoid it interference during the approach. This is the flap, the nasoseptal flap that you prepare for close the sella after surgery. Then posterior septectomy is performed, followed by removal of the face, the sphenoid. The conchal bone is removed using a diamond drill, and as you can see, the floor, the cellular floor is removed. In this case, we remove also the part posterior of the sphenoid planum. We open the dura in cross. As soon as the tumor caps is open, the cyst flow, and of course, the tumor decompress. Here you can see open the dura and the cyst decompress. The capsule is dissected gently from the neurovascular structure, always coagulating. We remove the capsule from the neurovascular structure, gently, of course, always coagulating. Here you can see removing the pars posterior of the tumor under the chiasma. Here you can see the chiasma. The tumor was totally removed, as you can see. You can see the chiasma. After tumor resection, the dura defect is repaired using artificial dura into plane and tucked it under the dura. This is the artificial dura mater under the dura of the patient. Then the nasoseptal flap and glue. We use nasal packing in both nostrils. Here the patient 4 months after surgery, the cell is totally recovered. This is the control, the postoperative control without tumor. Years ago, it was said, this is the tumor before and after surgery, of course. Years ago, it was said that this technique was not appropriate in children due to small nostril, narrower nasal cavity, immature pneumatization of sphenoid, short distances between carotid arteries. But with respect to the pneumatization of the sphenoid sinus, there are 3 types. Conchal types, where the sphenoid is not pneumatized, cellular type is completely pneumatized, that is in adults, and precellular, that is partial pneumatized. We advise using this technique in children as of 5 or 6 years of age because at this age, the distances between the carotids are researches 80% of an adult, and the manipulation of a skull base does not alter the mediofacial development. The disadvantage that you present themselves with this technique are the cases where tumor extended laterally beyond carotidal arteries or are trapped in vascular structure or are purely intravesicular lesion. We suppose in cases of massive hemorrhage, it would be very difficult to resolve, although luckily we have never had a case. The advantages of this technique is not only can craniotomy and transfacial access be avoided, it also prevents brain retraction, a better visualization of the undersurface of the optic chiasma and of the hypothalamus wall. Blood loss and surgical time are reduced, and as we said, there is not impact on the craniofacial development of child. But in cases of retrochiasmatic location, which is the most common in children, representing 80% in our cases, we perform frontoterian approach with opening of the lamina terminalis. We know that many general neurosurgeons have experience in the extended endoscopic Indonesian approach for these cases, but we don't. Here, we are working between optic nerve and carotid artery. Here, between both optic nerve, you can see carotid artery, and now we are removing the tumor piece by piece, and we remove the tumor before the chiasma. We open the liquid membrane, and now we are open the lamina terminalis, and we remove the rest of the tumor. We always open the lamina terminalis in order to remove the remains of the tumor located in the subventricle, and in this way, push the tumor from behind. Here an example, the tumor with a big cyst in the posterior fossa that was removed in the same procedure. This is the patient before and post-surgery. Here you can see the optic nerve compressed, another case of course. Here you can see the optic nerve compressed by the tumor. After opening the capsule, the tumor capsule, the liquid come out and the cyst decompress. Now we are removing the arachnoid and of course coagulating the capsule of the tumor. And we start to remove the tumor. In this case, is a very calcified tumor, so we remove it piece by piece. And when the tumor is very calcified, as in this case, we remove using the ultrasonic aspirator. since it's very hard, we break it up with ultrasonic aspirator. The tumor was totally removed, and here you can see the right optic nerve, the chiasma, the right carotid artery, the communicating, here you can see the communicating carotid, here, carotid communicating, and the left carotid artery on the other side. You can see here that the stalk was cut. The luic membrane and the clivus totally free. With regard to preserving the stalk during surgery, there are different opinions. According to this paper, the decision to preserve the stalk does not guarantee preserve endocrine function and comes with a higher risk of progression and need for adjuvant therapy. Other publications recommend preserving the pituitary stalk in craniopharyngoma with normal pituitary function. Another paper, in this paper, the conclusion is that preservation of the pituitary stalk, they found it difficult to rescue anterior pituitary function. We agree with some authors that recommended to preserve the stalk only in cases with normal pituitary function. But if the patient already presents endocrinological complications, sacrificing the stalk avoids recurrence and radiotherapy. On the other hand, despite attempting preservation of the stalk, it is difficult to rescue pituitary function. This is our experience in Garden Hospital children and the Trinidad Palermo Clinic in Buenos Aires, Argentina. Between 1988 and 2018, we operated on 378 craniopharyngiomas. The learning curve is very important. As you can see, I don't want to show because I'm afraid the picture grows. But as you can see, in our first year, we had more frequent complications in late and perioperative mortality. That is why we decided that only 2 neurosurgeons were to operate this tumor here in 2000. And you can see in the following 20 years, there was only 1 case of perioperative mortality. This is the last year. Unfortunately, in our country, I suppose in India the same, children come to consult with very large tumors. We achieved total resection in 70 and subtotal in 24. In cases of subtotal resection, as let me show, we indicate radiotherapy in children over 6 years old. Of course, the recurrence is higher in cases of subtotal resection. With respect to visual acuity, only 12% of children presenting normal visual acuity at consult. Also, 2 have normal visual acuity, but children that came to consult with severe deficit, only 21% improved vision. And those that came blind did not regain any visual acuity. But endocrinological function worse in almost all cases. 64% presenting endocrine dysfunction at consult, and in post-op, it grew to 87%. The most affected are those with ACTH, deficit rising from 10% to 72%, and those with insipid diabetes from 14 to 50%. Our most frequent complications were due to subdural hematomas and seizure. In large cyst tumors, like this is our complication. In large cyst tumors, like seen you here, of course, after surgery, the total resection obviously reduced the subdural collection. We treat with subdural tabs, but sometimes, like in this case, a subdural peritoneal shunt is required. On this patient, of course, we did the bicoronal approach. Finally, we can say that children under 5 years of age with hydrocephalus and hypothalamus disorder have a bad prognosis. On the other hand, children over 5 years of age without a hydrocephalus, with a small tumor and without hypothalamus disorder have good prognosis. Due to children's long life expectancy, we must take an aggressive approach given that limited resection irremediably implies recurrence. On the other hand, radiotherapy has in children long-term adverse effects such as poor cognitive outcome, vasculopathies, endocrinopathies, radiation. Thank you. I beg your pardon for the difficulties with my presentation.
Thank you very much. Thank you, Graciela. You are not sharing screen anymore. It's very good. We have two queries from Dr. Parek. The queries to you, Graciela, is whether you've seen any difference in visual deterioration between endonasal and transcranial, and also about the recurrence rate. I don't know if you have this data, but anyway, these are the two questions that appear in the Q&A.
No, I think there is no difference in both technique, but in cases that you can practice endoscopic endonasal, the vision of the underface of the hypothalamus is very important and is very good. But in traditional technique, you can't. You can to see exactly under the chiasma, and always a small piece of tumor stayed here, and you can remove. Although open the lamina terminalis, opening the lamina terminalis. That's why I prefer endoscopic endonasal approach in these cases. In prechiasmatic craniopharyngoma and in few cases of intracellular craniopharyngoma. In children is very few cases.
There's another question from Dr. Mani, whether you experience chemical meningitis from spillage of the fluid of the cystic part.
Excuse me? Which is
if
the
you
question?
experienced any chemical irritation or chemical meningitis from the fluid, some people think that once
Yes.
you,
I
the
understood.
oil, you know, the machina oil is spilled to the CSF, you can get mechanical, chemical meningitis. What is your experience?
It's true. But we wash a lot. We wash a lot during the all surgery. But I never had a chemical meningitis for the liquid, of course. I don't have experience and don't like intracyst injection of etune or any other bleomycin. No. I don't have experience, but I don't like have experience in that method. I don't believe.
Any questions from the panel?
You say
Sorry.
are also intermediate methods, not definitive methods.
I understand.
Right.
Thank you.
Thank you very much.
Any comments from the panel?
Yes, we can invite comments as well as questions. Any questions from my co-host Liu Boon Seng or Professor Shubin? Professor Shubin, any questions from you?
Yes. Thank you for your presentation, Professor Zuccaro. So, how to deal with the hypothermic reaction after the operation? Do you use some special treatment for the hypothermic reactions? So, normally, it's I think it's a dangerous complication after surgery.
Complication after surgery?
Hypothermic reaction, like
You mean fever?
Fever?
yes, sometimes fever and sometimes diabetes insipidus.
No, of course, after surgery, the patient is in the care, and of course, endocrinological situation is treated by the endocrinologist, but no other fever, no.
Raja, how much time do we have?
We have 10 minutes for discussion.
10 minutes. That's good. All right. More comments from the panelists.
Yes.
If not, I have many comments, but
Yes.
let's hear the panelists.
Yes, my saying you can ask your question.
Thanks, Raja. Thanks, Professor, for very nice lecture, Professor. I want to find out from Professor, what is your experience on long-term outcome of those patients treated with radiotherapy? Whether how much the tumor control compared to those who didn't receive radiotherapy, if you have any experience. My second question, Professor, in those cases that intraoperatively we think that we have completely removed the tumor, what are the risks or the incidence or recurrences, and how many times can we do surgery while buying time to wait for radiotherapy, for example, Professor? Thank you.
Sorry, I don't understand the question, because he
was asking about the long-term.
Yes, no, and the screen is not clear.
Yes, he was asking about the long-term results with and without radiotherapy after surgical resection.
We practice radiotherapy. Of course, we don't have proton beam. In my country, we don't have proton beam. We practice radiosurgery, gamma knife, in cases of subtotal resection when some residual tumor, of course. Gamma knives, you have to wait for 4 or 5 years. And in our experience, only 4 or 5% after radiotherapy, the tumor grow. And it was very difficult to operate after radiosurgery. In the few cases that we operate after radiosurgery, we can't remove all the tumor. So in these cases, after 5 years, we practice radio gamma knife again.
We can ask our chair also the same question, Professor Shlomi Constantini. What is your experience? Long-term
Look, I've got to say, the audience have heard two different approaches to craniopharyngoma. It's good because, as we said in the beginning, the options here. I think that we've been misled, to say that the recurrence rate after GTR is 3%. This is not something that has been reported in the literature. The lowest number that you can find in the literature is 25%. But if you wait for over 10 years, it will reach 50%. The other thing, if you give radiotherapy to children, it is considered, non-acceptable to give one dose radiosurgery. You always give full fractionated radiotherapy. And I'm not so sure that protons is so much better than photons, but it is considered in the Western country as state of the art, so as to reduce the spillage of radiotherapy to both temporal lobes. So I think that it's become very, very acceptable for the cystic craniopharyngiomas to do minimal surgery and then to irradiate. And for the solid one, that's a problem, and that's a challenge. The other thing is what is considered acceptable and what is not acceptable. So, for example, diabetes insipidus in a Western country, if the thirst mechanism is preserved, then it may be acceptable. But if the thirst mechanism is not preserved, it's a disaster. So if you go to the posterior hypothalamic area and you have the eye without thirst mechanism, it's a disaster. If you have hypothalamic obesity, it's a disaster. You don't need to wait for hemiplegia, for blindness, in order to declare a disastrous outcome. So I think for the cystic ones, the jury is out. For the solid ones, I have some presentations, but we don't have time for that. That's a different story that needs to be discussed sometime else.
Well, thank you very much. We had a wonderful session and a lot of learning today. I thank Professor Zuccaro and Professor Shlomi Constantini for the time and support for the ACNS webinars. And special thanks to Professor Shubin for airing this on the WeChat channel. And as of now, we have around 485 people who have joined live on WeChat and another 20 on Zoom. So there are around 500 people who have joined us live today. Thank you very much for this kind participation, everybody. With that, we come to the end of the first session. Thank you very much
for the invitation, and sorry for difficulty with the presentation. I don't know why, but I'm sorry. Thank you very much for the presentation.
Thank you very much. Very kind of you. With that, we can move on to the second session. I would like to invite Professor Franco Servadei to say a short introduction, and in turn invite Professor Andres Rubiana. Professor Franco Servadei, all yours.
Hello. First of all, thank Raja, Professor Cato for the invitation. Thank to Professor Zuccaro for the very good presentation on craniopharyngoma. I say a very good hello to my friend Shlomi Constantini. We know each other since years. And I also encourage everyone to go to Jerusalem for the first week of September to the Asian Australasian Congress on Neurosurgery with a wide spectrum of topics. And in Jerusalem also is a very nice city to be seen. So I advise everyone to go there. When going back to our topic of today, we learned by time that the world is not the same. And neurosurgical world is not the same. As we all know, there are about 50,000 neurosurgeons in the world, but quite a number of them, around 15,000, are living in countries with limited facilities. So we do have disparities between one part of the world and another part. I give you an example. These 15,000 neurosurgeons, which are about 1/3 of the neurosurgeons we have in the world, will publish only 5% of what is published in the neurosurgical literature. So there is big disparity between those who are working in countries with good facilities and those who are working in countries with limited resources. In neurotrauma is even worse because neurotrauma is endemic in some part of the world, Africa, Southeast Asia, and in many countries where the resources are limited. So when we deliver guidelines for management of neurotrauma, which are supposed to be valid all over the world, they are valid only for high-income countries and are made for them. The limit of the guidelines evidence-based, and if you don't publish, or if you don't publish high-level papers, you will not be included in the guidelines, and therefore what you are doing will not be showed and will not be useful for the production of guidelines. I just tell you, we have made a review. One last thing, the word low middle income countries appeared in neurosurgery only in 2015. And only since 2017, we have quite a number, let's say, of publications dealing with a specific part of the word. So neurotrauma is a prototype of what we can do in neurosurgery to be able to treat our patients all over the world. And I'm very happy to give the word to Andres Rubiano, who is from Colombia. Actually, now he's in Italy, but he's from Colombia. And he will speak. He has a very large experience. He is one of the few people from that part of the world who has always been publishing. And we are really very happy to have him here and to hear from him the experience of treatment of neurotrauma in countries with limited facility. Andres?
Hello, thank you, Professor Servadei, also for the kind invitation of the group from the ACNS, Professor Raya, Professor Bean, Professor Cato. And the idea is that we are going to share briefly some of the work that we have been doing in this specific topic that Dr. Servadei just mentioned. We are going to call this lecture Strengthening Neurotrauma Care for Areas with Limited Resources. And thanks to many of the entities, institutions, societies that have been working with our group recently in order to take this endeavor to a more organized fashion. So part of the work that I've been going to show was supported by the Global Health Research Group in Neurotrauma of the University of Cambridge through a grant of the National Institute of Health Research and our research foundation in Colombia, Medic Foundation. So briefly, the objectives of the talk will be to understand the concept of managing neurotrauma in limited resources settings, also to analyze the disconnection between current international guidelines and protocols and their applicability options in areas with limited resources, and to present recent consensus guidelines and protocols focused on the management of neurotrauma in limited resources settings. So when we talk about limited resources settings, there have been several definitions. And most of them have been very dedicated to specific booklets of WHO trying to deal with all these specific contexts that needs a lot of support from different areas. So we understand that one of the cornerstones of the Universal Health Coverage Initiative is the equal right to access for health infrastructure, supplies, or human resources. However, too many people worldwide suffer unnecessarily because they lack access to these elements partially or totally. And in these limited resources settings, the issue is critical as is required appropriate, available, accessible, and innovative interventions to fill this gap. So when we arrive to the definition, limited resource settings refer to settings where healthcare systems do not meet the standards by multilateral organizations in the field, like for example, the WHO, in terms of infrastructure, supplies, or human resources. And the effects of healthcare-related inequalities are most evident in these scenarios. So settings are often not explicitly defined, and umbrella terms like low to middle-income countries, less developed countries are often used. Recently, the concept of being based only in the income has been changed to this more organized way of metrics, that is the Human Developing Index. The Human Developing Index includes other than the income, the long and healthy lifestyle, the knowledge, schooling years, and then the gross net income per capita. And when they come together, you really have a sense of what is happening around the world in many regions, especially as Professor Servade mentioned, Southeast Asia and Africa have been the more affected ones. And Latin America in the recent years has been growing a little bit in these type of indicators. When we evaluate the injuries around the world, most of these data come before the pandemic, especially this one that is the trend for the most active economically population between 15 and 49 years old. We still have that is something similar, and there are also overlapping and some data deficit in areas that do not report too much data to the World Health Organization. But in general, areas like Latin America, South Asia, and Africa have a lot of injuries and trauma deaths in these areas. So when we go specifically talking about neurotrauma, even TBI or spinal cord injury, based on this data, we understand that in general, TBI is one of the world's most important public health problems, considering the high mortality and also great disability that often affects young and economically active population. And we were trying to understand many of these data, but definitely there is a lack of data for many regions of the world. And when you try to analyze specifically the burden of these specific diseases like TBI, you are right that most data is coming from road traffic collisions that are generally an obligation of being reported by the Ministries of Health, but especially in very low resources settings, sometimes there is a low ability of data in order to understand how the disease is behaving there. So when we go to this global burden of disease study from WHO, these are some of the maps that can allow you to take into account how much is the burden specifically for trauma. We have here the economically active population maps for the global mortality for trauma. All the green boxes are related to injuries. Then if you go for the low development index areas, you also have a lot of burden for that. As you go to more developed areas also, it continues. So this term could be expanded to several terms which show that these settings are not unidimensional or dichotomous, like adequate or inadequate, reflects really a complex network of interrelated resources of limitations and concepts. Now that we are moving into something that is called systems thinking and systems science research, it's very important to understand how all these complex interactions are. So to promote knowledge transfer between settings and accelerating these innovations to promote health equity, all stakeholders like researchers, clinicians, policymakers can benefit from being more deliberate in describing the context in which every one of these work is embodied. So many of these interactions affects even issues as financial level, geographical level, knowledge level, infrastructure development level, restricted social resources level, influence of belief and practices into their context-specific ways of thinking, also human resource limitations. So at the end, many of these complex interactions need to be understood, and how to tackle all at the same time is a very difficult task. A very good example of this is the recent emergency care system framework proposal from WHO, showing only for the emergency perspective how many of these issues affects the transit of the patients in different scenarios, like from the pre-hospital settings or the scene setting during the transport, and they're arriving at the facility, moving from the emergency areas to the surgical areas and also to the rehabilitation areas. So all these actors interact and all these processes interact in order to affect the final outcome of the patients. I just want to show some examples about providers availability or distribution with some of the global surgery groups from the University of Rutgers in United States. We did this recently analysis of the 6 core surgical indicators from the Lancet Commission on Global Surgery in Colombia. And we found that actually there is a high operation volume, but it's really concentrated in some areas of the country. If you have the light green areas are mostly the Amazonian region and so on of the border with Venezuela, where there are providers for surgical care, and in this case also for neurosurgery. So we still have like 6 states in the country that does not have immediate access to neurosurgery. So this is just an example of how the distribution of the human force within the countries affects as much many of these situations. So that's why in many regions of the world, there are some discussions about task shifting or sharing in neurotrauma. We understand that regularly there are near to 5 million total operative cases of TBI and spinal cord injury combined in LMICs every year. At a minimum, there needs to be one neurosurgeon performing neurotrauma cases per at least 200,000 people. So the evidence also suggests that patients should be ideally within the first 4 hours after the trauma to arrive into a neurosurgical facility to improve outcome. So there is a lack of neurosurgical workforce that is needed to really address the issues of neurotrauma in LMICs. So touch system of sharing is ongoing in many LMICs, especially for emergency trauma procedures, without substantial structural oversight, which is concerning for patient safety issues. But the data invite to future clinical outcome studies to assess the effectiveness and discussions of policy recommendations like standardization of curriculum, certification protocols, and many other issues that are related to this specific lack of specialist workforce. So in some areas, this is a critical issue, and still there is a lot of discussion about how to move with these aspects. This is a recent publication related to surgical task sharing physicians in low resource settings globally, and you can identify still many countries where all these situations are regularly faced. So due of all these issues, in 2016, the World Federation of Neurosurgical Societies with the World Health Organization meets during one of the international conference for research advances in neurotraumatology in Bogota. And we bring together with many of the authorities of the meeting and also some of the local health authorities in Colombia to present something that was called the Bogota Declaration. And the Bogota Declaration is actually how many of these endeavors start from the global neurosurgery perspective at the World Federation of Neurosurgical Societies. So for all that are not familiar with the Bogota Declaration, I just gonna read most of the principles that were stated based on what Professor Servade already mentioned. Most of the unmet needs are in low and middle income countries. A preliminary assessment of the unmet neurosurgical care is alarming. We affirm that we have responsibility for providing neurosurgical care to all who need lies with the global neurosurgical community. So we declare that the global neurosurgery is a collective and unified effort on improving all aspects of neurosurgical care whenever and wherever is needed. And we call on the neurosurgeons as well of all the professional societies of the world and related stakeholders to take urgent coordinated action to lead and address the unmet global neurosurgical need. So when we focus all these context and aspects specifically on neurotrauma and the current international guidelines, we found that there is a disconnection between many of the recommendations, evidence-based, and how to apply that for daily based care of the patients worldwide. So we are in an era where many societies and many countries are developing their own guidelines, mostly based on the same methodology based on evidence. But sometimes when you try to apply this to the specific context of the patients, they not fit even sometimes in the same countries, but also you can imagine how we can generate a barrier if you want to apply many of these recommendations to some more limited resources settings. It also applies for some of the spinal cord injury guidelines. So most protocols and guidelines focused on neurotrauma management are developed in areas where advanced technological devices are used for treatment. These are not worldwide available. This current situation creates an important gap in knowledge transferability when it is required to adapt or develop local protocols of care. being more critical in situations of resources limited settings. These conditions generate an important frame of heterogeneity for decision making in these scenarios, and when it ultimately is affected, it is the patient and all the patient safety associated to this. We know that there are some quality improvement recommendations for most advanced systems, but when we try to apply that in areas that does not have all the resources, it will be difficult to interact with the system itself. We understand that adherence to guidelines in adult patients for TBI or even spinal cord injury can generate some barriers. They have identified some barrier for this adherence process that have sometimes are related to the resources available for care, and sometimes it's also with the human factor of the people that interact within these settings. It is interesting to know that even in high-income countries, there are differences when you talk about rural versus urban outcomes. We recently published this paper evaluating the differences in outcome for severe TBI patients in the United States. And in rural America, definitely there are areas that have poorer outcomes compared with more urban areas. So trying to tackle these aspects, some system science approach are coming to be integrated for something that we consider is a system problem. And the group from Cambridge has been integrated with engineers that work with system science in order to tackle these aspects. So some suggested interventions include to develop capability level in low resources settings that include also works not only at surgical level, but also at primary care, basic emergency care, and public health systems. These include also education for families, community healthcare workers, and clinicians, in addition to infrastructure support such transportation or communication systems. It also generates capacity by increasing the surgical and critical care expertise in human resources that are already settled in these areas. And something that is very important is also that professional society needs to start the discussion about how should advocate broadly to mitigate the intellectual drainage of health providers from low resources countries. Many people from these areas are able to receive advanced training in other countries more developed, but mostly they decide to stay in those countries and don't return to change practice in their own countries. So investment in education and development of processes where limited resources can be applied to those patients most likely to be more beneficiated from the intervention. So between all these suggested interventions, there is one that we can easily move in order to start changing this paradigm. So in order to mitigate the needs, the development of simple triage tools, protocols, and care guidelines modified to resource limitations that can be used even by health workers with limited clinical backgrounds is an important aspect. So based on that, we have been working on this type of efforts. We understand that emergency care management strategies for patients with neurotrauma should be adapted to local environments. Particularly important is early identification of surgical indications if any neuroimaging system is available or even if not. So the most common neurosurgical procedures performed worldwide are those related to the care of neurotrauma, including countries with resource limitations. So in some cases, as we mentioned before, task sharing with general surgeon for performing basic procedures like boreholes or management of depressive factors has been proposed. Patients in this environment must be constantly reassessed in order to identify potentially fatal injuries that require timely interventions, especially those with moderate cases with borderline clinical signs. The use of tools like the WHO Trauma Care Checklist has been shown to reduce failures in the emergency management of general trauma patients, including these neurotrauma patients. So this is very important, and in many of these settings, there are not only neurotrauma isolated cases, but also accompanied by polytrauma. So it is very important to prepare the teams locally to understand the full management of general trauma patients, especially at the emergency room. Since many years ago, we have been working on the development of this type of protocols and checklists. This is some of the examples that the study that we have been published related to organization of standardized trauma care protocols and how they are related to decreased mortality, especially for TBI patients with very basic interventions, like organization, airway management, and the use of osmotic therapy and hypertonic fluids for aggressive resuscitation. Also use of early blood products if available, interpretation of arterial gas blood draws if available also. There are some guidelines or protocols that have been developed since many years ago for areas that regularly have these kind of environments, like rural Australia, for example. This is an example of the Neurosurgical Society of Australasia guidelines for the management of acute neurotrauma in rural and remote locations. It's a very useful tool if you want to work in this topic. Also in India, there have been some efforts trying to develop recommendations for the Indian context, also some guidelines. These are some examples of the guidelines that we have been working with the Ministry of Health in Colombia. And when talking about the use of guidelines versus protocols, is very important to understand that transferring general guidelines recommendation to practice in these environments is sometimes challenging due to the wide variations in terms of resources, training, and circumstances. So in this situation, specific protocols have been considered more useful in terms of impact the patient's outcome. Based on that, there have been some recent proposals for working in low resource settings, like the CREVICE protocol from the group of Dr. Randy Chestnut and also a group of Latin American intensivists and neurosurgeons. We were working on this around 2018, and it was finally published in 2020. And this is only based on the acute management for patients defining having association of high intracranial pressure findings and the general medical exam. Also, there is a map for trying to suggest to the ICU practitioners in this setting how to de-escalate aggressive therapy in patients based only in those criteria. More recently, we developed this concept of the stratified protocols. This is the project called the Bootstrap Beyond One Option for Treatment of TBI, recommendations of the Colombian Consensus Committee for the Management of TBI at pre-hospital, emergency department, surgery, and intensive care level. So really are near to 10 or 12 protocols that can be adapted according to the resources on each one of the centers that are taking care of those. If you want to have a sense of the process itself of the methodology, this block map is the most easy one to understand the process. Each one of the blocks represents a protocol that can be used in one of a different scenario. The first one are related to pre-hospital care. So you can have areas where there is only availability for very basic emergency transport, even without resources or even with low training level. And you can apply even there a protocol. Then you can be in a pre-hospital setting that have more intermediate resources like the yellow box, or when you can be in an area that have all the technological resources and also better training level, that is the green one. And from that area, you can move also to an emergency department that can have low resources, intermediate resources, or high resources level with or without CT scan. And from there, you can move to centers that have neurosurgery available or only have general surgery available. And then you can move to areas where you have just general wards of post-operative care or even intensive care units. And in that way, you can advance through different protocols and algorithms in order to move for evidence-based and expert practice in order to improve outcome of the patients. This is the link for the actual paper that is published on the Journal of Neuroscience in Rural Practice, but the most important thing is actually not the paper, is the supplementary material that is associated, where you can find the step-by-step protocols for all the people that want to implement something similar in their centers. As This process has become a lot of traction and attention because it can be easily reproducible in many other areas of the world. More recently, during the World Federation Neurosurgical Society meeting in Bogota in March of 2022, we moved for an exercise of starting also a bootstrap project for a spinal cord injury. So the bootstrap spine start during that event. We have people with representation from several regions of the world: Africa, Southeast Asia, Latin America, also Europe and North America. And we become together in order to have 4 different tables, one for pre-hospital care, one for emergency department, one for surgery, one for intensive care. And we are now in the process of developing the systematic reviews and also all the final summary of the recommendation for each one of the table in order to build the algorithms. So we are in that process. We will hope that this will help many people around the world. In order to finish, all these will be something that will be incomplete if we don't understand that starting to collect data into these environments will be something that will be needed in order to change the paradigms. So the importance of data collection and effective research models for low resources settings or limited resources settings is also important. We are all familiar with these 2 big studies that have been done in North America and Europe, that are the track TBI and the center TBI, following patients for more than 2 years in each one of the centers that are participating. There are a lot of budget involved in these 2 trials, near to $60 million or 60 million euros, in order to collect some data, even with biomarkers and advanced imaging data. But if we don't follow that pathway for these limited resources settings, we will have a huge gap in order to understand what is happening, even if we develop these protocols of guidelines. So an example of something that can be done is the project that we actually have with Neurotrauma Registry for the Latin American and Caribbean region. We also are in the active data collection process. We just finished the pilot recently with an important number of patients inside the database. This obviously didn't have the huge budget that I referred previous to the other 2 studies in North America and Europe, but we are trying to do our best in order to involve and collect data and understand what is happening with the intervention that have been performed in many of these settings. So we are actually involved many centers from Brazil, Colombia, Ecuador, Peru, more recently some of the islands of the Caribbean region. And the idea is that at the end, we are going to have a really good picture of what is happening in this center with the patients. Obviously, it is very important to maintain during this system approach view all the campaigns for prevention. This is the prevention campaign that is linked to the registry itself, where you have a lot of tool videos that allow to move all these prevention concepts for TBI, even at the school levels and also at the associations level for different populations, including children, young adults, and elderly people. And finally, you can complete many of these system approach with improving the training in your own settings. So what we have been done since some years ago is an important collaboration between the Barrow Neurological Institute at the Finnish Children's Hospitals and the University of Cambridge and our center, research center in Colombia, trying to bring together expertise from many people that is interested in this topic. And we have created a fellowship program that is lasting for 1 year in order to bring neurosurgeons from LMICs that can understand better these concepts and can start practicing in these concepts and doing research specifically to take that message back when they return to their countries. So in 2020, for example, we received applications from Cuba, Pakistan, Nepal, Egypt, Venezuela, Qatar, Uzbekistan, and Emirates. We have been certified now actually more than 9 or 10 neurosurgeons from the specifically regions of Colombia, Brazil, USA. And we have been published recently this effort sustained and supported by global efforts like the one that it has been developed through the Global Neuro Foundation about a specific curriculum for international neurosurgery residents and neurosurgeons that want to focus on neurotrauma care. So we work based on those competencies in an interesting network of collaborators from the Latin American region and also, as I mentioned, Europe and North America. So our fellows spend 6 months in Latin America, mostly in Colombia, also have some small trips to Brazil, and then move also to Cambridge and also to Phoenix in order to have a complete picture and panorama of what is happening. The most important measure that we have from this is that developing this type of collaborations really support the generation of new trends in order to tackle this situation. Now we have been able to doing a lot of research using non-invasive methods, for example, for early high ICP detection, also for detecting intracranial bleeding in absence of radiological suites. So all these efforts have been creating a really important cadre of people that maybe can be moving for the next stage in other countries as well. If you want to have a more summarized version of this talk, we recently published this article on brain injury about management of severe TBI in regions with limited resources. It is open access, so you can actually can have many of these concepts. And also, after many years, we were very lucky to participate in the Humans and Wings Neurological book with a specific chapter of TBI management in resource challenge environments, where we share some of this experience with a specific aspect like indication for transfer to centers without or with neurosurgery and neuroimaging services, and also the algorithm for define transfer or surgical management of patients if you don't have like a CT available, how to work with devices like the pupillometry, the optic nerve sheath diameter evaluation by ultrasound, and also the infrared scanner, that are devices that have been recently used in areas for military operations, but also can be applied to this type of settings. So this is all. Thank you so much for this kind of opportunity of share these concepts and knowledge. We understand that emergency care, it is a part of a discursive regime of immense social importance in which those who live and die are measured. And we understand that the political way of medical science interacts over the debate about healthcare provision in any society. This debate with symbolic significance for any caring society have political relevance and huge economical implications for members and administrators of that society. And health educational and research are fundamental elements to build appropriate well-being and social development in such society. Thank you so much.
Well, thank you, Andres, for your very good presentation, which was comprehensive of all the problems we have in treating injuries in many parts of the world. I push the participants to send us questions. I don't see questions at the moment. I think we have to, if possible, to get some questions. Well, I have many questions, but I don't want to monopolize the discussion. I think it's better if we start with some questions from the panel, and then if we don't have any other question from the floor, I will interact with you.
Right.
Raja, if you want.
Yes, of course, we can take questions from the panel. My co-host, Dr. Libun Singh, any questions from you?
Thanks, Raja. Thanks, Prof, for a very nice presentation. Professor, I wanted to find out from you, we have ACNS, we have ATLS. Do you see that we may need a neurotrauma life support for the emergency care in throughout the world? My second question, Professor, regarding medical legal fraternity, they don't look guideline according to resources. So do you think that in the future, the guidelines should be documented as guideline for high-income country and document those for low-income country, Professor? Thank you.
Thank you for the kind questions. Yes, I think short courses, like you mentioned, like the ACLS, ATLS, focus on neurotrauma care will be important. Actually, those type of courses are the courses that we regularly do through Global Neuro Foundation. We just did a couple of days before in Brescia, a really nice course for residents of 2 days, including practicals and theory. But as you see, the issue is too big and the interactions of the different factors are too big that just a course like that will not be enough. It is important, but it not will be enough. So from the Global Neuro Foundation perspective, we have been developed 2 type of courses, one for basic areas that does not have too many resources and the other for more advanced areas. But definitely the ideal situation will be to have at least in each one of the countries a fellowship program, like the one that we have, that really generate a totally different picture and panorama of the people. Because if you see, and I will appreciate having also Professor Servade's opinion regarding this issue, is that when you go even in these areas and you speak with the residents there, they are regularly focused on topics that even if they are not public health important topics for the country, are topics that, you know, it generates a lot of revenue for the neurosurgical perspective. So it's important to understand that in areas where trauma is a big burden that generates an important problem at the health system locally, we need to have people specialized in neurotrauma care, because neurotrauma has been sometimes seen very simple, but the importance of interacting with intensive care concept, postoperative care concept that are really needed. It requires a more longer training process. Like, you know, most of the fellows right now for neurotrauma care are concentrated in Europe and North America, but we need it in other countries that are more affected by trauma than these settings. So that about the first question. And the second question, being discussed that topic specifically, and definitely it seems like if we continue with the actual living guidelines, systematic reviews that are focused on evidence-based medicine, we are going to have a lot of gaps that sometimes creates difficulties when you try to bring that from the guideline recommendation to the actual practice. And that's why where protocols can generate a difference. And maybe if we are developing guidelines in general, independent if they are for high-income settings or low-income settings, the most important is try to develop protocols that really connect the recommendations of the guidelines to the very context facility-based. That's why our Bootstrap project has been calling attention, and we are now actually in the process of evaluating the impact of the protocols in real life. And if this is successful, the idea is to have, we are doing this right now only in Colombia, but if this is successful, we really want through the World Federation maybe to propose a big study that we can have many countries involved in order to test this.
Thank you very much. One thing that I would like to ask Professor Rubiano is about the pre-hospital care. What we miss in the resource-limited setting and the expertise for pre-hospital care in managing these patients, because that is a golden hour of trauma where patients benefit from accurate avoiding hypoxia, hypovolemia, and everything. So when we are talking about resource limited setting, we are missing this very important aspect of pre-hospital care. What have the Brain Neurotrauma Foundation, is in which you are the chair, what steps have you taken in, or are you planning any future endeavors regarding this aspect of neurotrauma?
Thank you, Dr. Raya. This is an important point that we mentioned during the talk, is that when you want to improve care at this level in limited resource facilities, we do not only need to focus on surgical care, but we also need to focus in this kind of aspects from pre-hospital care. So if we are knower of the Brain Trauma Foundation guidelines, there are actually guidelines that are going to be updated recently for the pre-hospital care, but it also creates that gap that sometimes are based on technology that is not available in all the countries. If you see the recent guidelines from the Indian Society of Neurotrauma, they mention about how to the importance of this process. And what we are doing now with Global Neuro Foundation is that actually we are piloting a specific 2 days program for training pre-hospital provider for neurotrauma care. The idea is that we are going to finish the process this end of the year in the Latin American region, and then we will be moving the course across all the countries for next year. So that's a very important topic. Thank you.
Thank you, Professor.
Well, if I can add something to what Andres and our colleagues have said, there are many aspects. One aspect, one piece of this story on treating neurotrauma, when I became the president of the World Federation, everybody knew that I had a specific interest in neurotrauma. And I say that as it's not only me, the World Health Organization is saying that one huge part of the world surgical care is in trauma. For us, it's neurotrauma. But the objection was, in countries with limited facilities, they don't have pre-hospital care, they don't have rehabilitation. Until they don't reach a good level of pre-hospital care or rehabilitation, we cannot talk about treatment of neurotrauma. Raja, you know that in many parts of your country and in many parts of Southeast Asia, because we are today with the station, there is very limited pre-hospital care and almost no neuro rehabilitation. But at this point today, there are neurosurgeons operating on trauma. So we are dealing with trauma, even if the resources are limited before and after our treatment, but we have to deal with this. This is the target of our work. It's not saying we don't do anything because the outcome will be very bad. It's saying, as Andres said, we give an example of how we can improve neurotrauma rehabilitation and how we can improve pre-hospital care. The other question is, when we try to help countries with limited facilities from Italy, let's say, we very often, we don't understand how we can help these people. I've been traveling all around the world. What you see is different from what you think. I give you an example, Andres, you know it very well. We have been trying to help people to do management of severe injuries without ICP monitoring. Very good. But the suggestion is a series of CT scans. If you go to sub-Saharan Africa or in many countries of the world, you have to pay for the CT scan. So 6 CT scans during the management of the patient are totally unfeasible. So what we do need for the future, for the guidelines, for instance, is to work together. We don't need to work on one side and you are on the other. An example, and Andres cited it, is what we call it consensus conference. In consensus conference, you don't need evidence-based medicine, or at least you don't need only evidence-based medicine. Even the practice of the surgeons who are discussing with you is important. So we need to find a way to work together. And in this aspect, I have a question for Andres. You know that in many countries, there is a sort of twin university system, like, for instance, Norwegian with Ethiopia, ourselves with Indonesia, the many American countries with Africa. Which is your experience, Andres, about this so-called twin university? I mean, a joint university between a Western university and a university in countries with limited facilities.
No, totally. I think that point is very important and is having a godfathering process from three universities, and our experience has been very successful. As I mentioned to you, we have been working in peers and also now with additional partners from different universities in the collaboration that we call the North-South collaboration. And I think this is a very productive process where they can interact and they can share experiences and also share knowledge. And the best approach with that is that we don't have that of knowledge that regularly happens when somebody is living outside one of these collaborations. So definitely, I think that process of having a godfathering processes from more resources settings to less resources settings will support a lot of changes locally. And the idea how to apply that transversally within a universal program that can be managed, at the World Federation level or at WHO level, that can be replicated worldwide.
Thank you. Other questions from the panel?
Professor Franco Saude and Professor Lubiano. Thank you for your outstanding contribution to the treatment of traumatic brain injury in developing countries. Talking about the limited resources, I think it's a relative concept. I think the high price of the neurological instruments is also an important fact to make the resource even limited. So China is a big manufacturing country. And actually in my country, the price of some instruments is only 1% of the 1% of the price in some developed countries. So myself donated some equipment to some developing country like Morocco, and I also buy some equipment on behalf of foreign neurosurgeons. So if possible, we can make some contribution. If you are interested in Chinese neurosurgical instruments.
Well, I can say immediately that the World Federation now has changed. Before, the set of instruments we donate to countries in limited facility, the microscope was a Zeiss microscope. Now we have a Chinese microscope, and the drill is also Chinese, and the instruments are from Pakistan. So we have realized that we can have good quality instruments by paying at least 1/10 of what we paid before. I don't know your experience, Andres, but this is an important issue. Having access to the world market of instruments, not only limit to our countries.
No, totally. I think that comment that Professor Bean have mentioned is really important. And talking specifically about neurotrauma, not only the surgical instrument, but also the monitoring devices. Like now that we have been focused on non-invasive issues, it's really important to have like affordable ultrasound machines. Also, there are some new trends in portable CT scans that have been available. So definitely, I think that disruption of the market will be very important in order to take many of these countries that need a lot of support, actually. So that's a very important point. Thank you.
Well, thank you very much, Professor Shubin raised a very valid point that access to standard surgical instruments is also a very important thing in neurotrauma. With that, we come to the concluding part of this webinar. If Professor Franco Sarvadei can say final concluding remarks.
Yeah, well, there is not so much to say. I think we have to thank the ACNS for this continuous education in a difficult period of pandemic where we are going up and down in waves with more or less cases. We can travel, we cannot travel. webinars have been one of the most important discovery of the pandemic. We say in Latin, ex malo bonum, means from the worst to the best. Sometimes we follow what's happening. And I give you an example. I had a webinar last week with the African neurosurgeons, and they were attending people from Mongolia, from Congo, from Guyana in South America, from Libya, from Syria, from everywhere. And these people before could not travel to Congress, could not listen to their mentors. They only could see them published, but they couldn't listen. One of the best of the webinars, they are free and they reach all over the world. We should never forget, I know that Subin agrees with us, we should never forget this experience. An hybrid system where we will have conference, but we don't stop webinar, it's extremely important. And I thank all of you for coming and giving us and the attendees this opportunity.
Well, thank you very much. Very well said, Professor Franco Servade. And as you said, webinars were the find of the pandemic. Today we add the episode number 213 in our relentless pursuit of education for the young neurosurgeons. So I would like to close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to thank both the speakers of today, Professor Graziela Zucaran, Professor Andres Rubiana, as well as the chairs, Professor Shlomi Constantini and Professor Franco Servade, for the time and support for the ACNS webinars. A special thanks to Professor Shubin for broadcasting this on the WeChat channel. And as I mentioned earlier, we have around 500 people who have joined on all three platforms combined. Special thanks to my co-host Liu Bun Singh for joining me today as well. So until we all meet on coming Saturday, it is bye-bye from all of us. Thank you very much for joining.